Hello, Health Psych. This is part 4 of the intro lecture. We are on Friedman et al.'s pathways, and we wrapped up part 3 talking about the stress management example. So let's go ahead and get that started. All right. Pathway number 3 is the behavior change pathway. And just like we talked about how all the leading causes of death are related to lifestyle behavior. If lifestyle behavior is driving medical illness, doesn't it make sense that we would encourage behavior change for individuals in order to either prevent disease or to treat disease? And part of the reason why you all are doing your own behavior change project is I want you to understand the tools that we use to help people change behavior when they're ready to change behavior. And then also to understand that the same types of tools or strategies or interventions, cognitive behavioral or ACT interventions or whatever we might be using, some things work really well for people and some things don't work as well. And so the art in psychotherapy, a lot of times, is figuring out and getting people started on behavior change, see what works for them. And if something's not working for them, tweaking it and trying something different. Okay, in this particular pathway, this is Dr. Dean Ornish. He is a cardiologist, and in his own personal history, when he went off to college, got really depressed, got suicidal, got help for that. And so he's a medical doctor, but one of those champions for behavioral and psychological services. And what Ornish, in his training, had a cardiology professor when they were in there and either doing bypass surgery or they're in there and doing angioplasty, and they see the clogged arteries built up with plaque. And his professor made him think about, okay, how did that get there? How did that plaque get there? And usually that plaque is a buildup from dietary factors related to animal products. Okay, you don't tend to get plaque buildup in the arteries because somebody's eating a plant-based vegetarian or vegan diet, as an example. And then the professor made him think about, okay, well, how did that get there? Okay, well, it's their lack of exercise. It was the way that they were eating, particularly too many animal products. Why was that going on? And he just made him backtrack enough to really appreciate lifestyle behavior in disease. Now, most cardiologists nowadays are much more interested in making a diagnosis, treating with meds, treating with surgeries, that type of thing. But Ornish was unique back in the 90s when he started publishing his research. So he developed a comprehensive cardiac rehab program. So this is post-heart attack, post-MI. And his program goes hardcore on diet, and he goes totally plant-based with the idea that if you're not consuming triglycerides, consuming cholesterol, and cholesterol we only consume when we consume animal products anyways, because humans make our own cholesterol. He goes hardcore with the idea, if you want to pull fat out of the coronary arteries and also out of the arteries that lead to the brain, you've got to go really low fat so that the body starts using its fat, both inside arteries and then, fat that we store on our bodies, go hardcore to really lower those fats, serum fats. His program is a supervised exercise program, and cardiac rehab programs always have medical supervision on site, just in case the exercise prescription for somebody could perhaps send them into an event. And usually the exercise prescription is written at a level by the exercise physiologist that we know is safe for individual patients. And then they will do their exercise while they have medical monitoring. And then once they adapt and train, get that training effect to that minimal level of exercise that was written for them, then they bump up the exercise. And most programs include aerobic exercise, like this dude on the treadmill. Most of them include resistance training and weight training. He has his patients engage in meditation and yoga, so that stress management component. He runs a support group in his program. And in one of his initial studies, and this was the cost of cardiac rehab program back then, cost $10,000 a year to have an individual in the program. But when you compare that to the hospital costs for Cabbage's bypass surgery, that at the time was running between $90,000 and $150,000 just for that surgical procedure. And he found that his cardiac rehab program, his very intensive cardiac rehab program, reversed heart disease. And he's got in his scientific articles, he even shows like pre-program how clogged the arteries were versus after they engage in his cardiac rehab program, how much success they have in reversing their actual heart disease. So basically what Ornish has been able to show is that you can put somebody in a cardiac rehab program. We'll talk more about this when we talk about cardiovascular disease. Post heart attack, it successfully helps them reverse heart disease. He's also been able to show pre-heart attack, so somebody who's a walking time bomb, that if they do his cardiac, it's actually not rehab at that point, it's more prevention. If they do his program, it reverses heart disease and prevents heart attacks and stroke. So somewhere in this, when we start thinking about our healthcare system, we'll talk more about this in cardiovascular disease, this should be mainstream medicine, but it is not. Okay, mainstream medicine is still the meds and the surgical procedures, angioplasty and bypass surgery for individuals post-heart attack or pre-heart attack. Another example of a simple behavior change, one study showed that if you mail older patients a health risk report and suggested lifestyle changes, usually just saying you need to change your lifestyle isn't really very effective unless you add a behavior change program to it. But in this situation, they found that just having these older patients get this risk report, like, I could be in trouble here, and you're encouraged to start exercising, eat more plant-based foods, whatever it might be, the suggested lifestyle changes, decrease their medical costs within the following year by 15%. So just giving people information and encouraging people to change behavior by an authority figure, which is usually their healthcare professional, actually works to some extent. And again, we're going to learn when we talk about behavior change, having people ready to change and wanting to change and setting goals and SMART goals is some of it, but a lot of times you have to add the behavior change project to it also. Okay, pathway number 4, the social support pathway. We're going to spend a whole lecture on social support this semester, but the basics here are, we know that people who are connected to others, who love and are loved and have particularly emotional intimacy with other individuals, are the healthiest individuals. People who are isolated and lonely are much less healthy. And if you add to that, it's one thing to be isolated and lonely. It's a whole nother layer to have been rejected and feel rejected. And so we are wired to be social creatures. And so social support is critical. This is just one example of a study that was done that showed how powerful social support can be for a woman who is in labor and birthing a baby. And we know that C-sections are one of the most common surgical procedures that are performed in hospitals, where they cut through a woman's abdomen and uterus, and they take the baby out through her stomach. It was named after Julius Caesar. His wife needed a C-section. She wasn't birthing her baby back in Rome, and the surgeons figured out how to get the baby out of her safely. And anyways, but we are performing way more C-sections in the United States than the World Health Organization says is necessary. That's driven by lawsuits, OBGYNs. If there's any distress, oftentimes in that baby, they will schedule an emergency C-section, get that baby out of there. Okay, so in this study, they had 204 women who were about to go into labor, and all of them got their medical care as usual. This is pretty customary in this research, but half of them got something special. They were randomly assigned a doula, spelled wrong down here, sorry y'all. They were randomly assigned a doula, and a doula is not a midwife, is not an obstetrician. sometimes they're he, but usually they're women, are specifically trained in just being supportive of the woman during labor and delivery. And in a lot of OB practices nowadays, the doulas will meet with the woman and maybe her partner even during the pregnancy, and getting her prepared for the event is going to happen when she's in labor and delivery. And what you see here is doulas do things like she's got her sitting on a ball, which can be more comfortable. She's massaging her back. If she's got back labor, she might be putting pressure on her back, helping remove some of that back labor. She might get her in the water in a tub or a warm pool, which a lot of women are doing, that eases birth. Feed her ice chips, make phone calls for her, whatever that woman needs, she's just like catering to her. And in this situation, having the doula with her, in addition to her medical care, reduced the rate of requesting an epidural, which is anesthesia that you put in the spinal cord that numbs the woman from the waist down, by 85%, meaning the mom was managing her pain much more successfully when she had a doula. It decreased the time spent in labor by 2 hours because the woman was relaxed and using her energy in those contractions to pull the cervix open and then push the baby out. Here's where the cost savings came in. It reduced the rate of C-section by 56%. So the women who had the doula were a lot more likely to have a vaginal birth than needing a C-section. It also decreased the percent of babies in half who needed to stay 48 plus hours. And those are usually babies who've had some kind of complications. So win-win for mom, win-win for the baby, win-win for the cost in the hospital. And at the time of this study, the doula cost $200 to have her there during labor and delivery. So we also know, I should have said this at the beginning, when women have the person in the room or people in the room who they want to have, it could be partner in the room with her. It could be wanting to have her mother or her sister or a best friend, something like that. When they have that person in the room with them, things go more smoothly too than if they are all alone when they are in labor and delivery. But adding this professional doula has an added benefit. So I wish I knew about this back when I was having my sons, but I did not at the time. Okay, pathway number 5 is the undiagnosed psychiatric psychological disorder pathway, meaning when we know that about 30% of medical patients have a psychological disorder, and if it doesn't get identified and it doesn't get treated, then that individual is still going to be suffering physically and accessing more health care. So in this thesis, this was Claudia Gerard, one of our former master's students, back when we had a master's clinical program before we had the doctoral program. And Claudia's husband was an ER physician. And so she had some access to some listservs of academic ER medical doctors. And what she developed were vignettes. And the vignettes either described a man or woman. So that was one of the factors, independent variables in her study. And the man or the woman either had a description of a diagnosis of panic disorder, but they didn't say panic disorder. They just said the symptoms, or the symptoms of major depressive disorder, depression. And she randomly assigned these medical doctors in the ER these vignettes. So they got one of the 4 vignettes. So man, woman, panic disorder, depression. And they read the vignette of this patient and their symptoms. And then they read about the tests that ER doctors would have asked for. And all of the medical tests that they would have asked for came back negative, showing nothing. And then these medical doctors were asked to give a diagnosis. What would the diagnosis be? And then they were given a list of things that they would do for referrals or for treatment for the individual. And what she found was 72% of these doctors, when they had major depressive episode, diagnosed depression correctly, which means about 30% of the depressed patients fell through the cracks and did not get accurately diagnosed. Now, remember, they weren't having a heart attack. The medical test came back negative. Only 33% of the panic disorder was diagnosed correctly, meaning about almost 70% of the patients who had panic disorder fell through the cracks and did not get diagnosed correctly. And this is a shame to me because both panic disorder and major depression are treatable. Okay, we've got psychotherapies, and there are also some medications that can be helpful that effectively can treat these disorders. But if they don't get diagnosed, so these individuals, would be, in the ER, they're not getting diagnosed. I remember in Claudia's thesis defense, we got in the giggles a little bit because I wanted to know, I said, if they're not catching that this is panic disorder, what were they diagnosing it as? And the number one thing that these ER doctors were diagnosing was tachycardia, which is just basically saying high heart rate. And yeah, that high heart rate and goodbye, you can leave now, you're not having a heart attack. Okay. In this study, what they actually used were real patients who presented to emergency department with chest pain, thinking that they may be having a heart attack. But the myocardial infarction, the MI, which is the heart attack, got ruled out. So real patients with chest pain, but they did tests and they're not having a heart attack. And then they gave them this really brief psychological screener that can make diagnoses. And what they found is that 17.5% of these patients would be diagnosable with panic disorder. 23% of these patients would be diagnosed with major depression. And so what this tells us is we should be in medical settings using some type of quick screener. And I like to use the PrimeMD. Let's talk about PrimeMD. You're seeing primary care MD. It's a screening device that it's a one-page document that a patient fills out, and they just check off symptoms that they've had in the last month. And on the PrimeMD, what it does is it screens for the most common psychological disorders. So it screens for anxiety disorders, it screens for depression, it screens for substance abuse disorders. It screens for binge eating as an eating disorder. It screens for somatization disorders. And then I add on my PrimeMD because I think this is really important. I screen for domestic violence, and I screen for a history of physical and sexual abuse and assault, because those things are really common and tend to drive psychological disorders. In this particular study, they had these patients who were going in for a non-emergency surgery to a hospital, and they screened them with the PrimeMD. If they flagged for any psychological disorder, a health psychologist got in there and gave them a really brief treatment. And what they found is that the people who got the brief treatment versus those who did not get the treatment were probably less stressed, suffering less from their psychological disorder that they screened for. And so they probably, after their surgery, they healed more quickly. You all saw in the New Medicine documentary, the Glacers and Kegel Glaser found in the patients with who were caregivers for Alzheimer's patients, their wound, remember their wound that they were given, healed more slowly than individuals of the same demographics who were not caretaking for a person with Alzheimer's disease. And so healing goes faster. They found that this program cost them $40,000 a year. That was to send the health psychologists around to do this stuff. But it saved that hospital $270,000, mainly because their patients were going into surgery, healing up quickly, and could be discharged before the hospital started losing money on them. So they make money from the surgery. If they keep them way too long, they start losing money, mainly because probably these folks were healing more quickly. Okay. As another example, pathway number 6, we call the somatization disorder pathway. And this is a category that can include a couple things. It can be people that are having stress-related physical illness in their bodies, and a lot of different diseases. When you add to it stress, or you add to it psychological disorders, that disease, it gets worse and doesn't heal, as well as people tend to suffer more. So one example of somatization disorder here could include individuals with chronic pain, but these could also be, there's a whole category in the DSM of psychological disorders that are more likely psychological disorders that show up in the body physically than psychological disorders that show up more in thoughts and emotions, as an example. And in one of the studies that they used here, they simply screened patients for somatization and randomly assigned, half of them got the intervention. And the intervention in this situation was a primary care doctor taking these complicated cases and just encouraging them to set up a weekly medical appointment so they could track them, they could give them attention and track their symptoms and be more thorough in treating what ailed them than waiting for them to be in this emergency situation where they would access care a lot more intermittently. And what they found that those who got that brief intervention in the following year, they reduced their medical costs by 30% relative to the control groups that did not have any change in their medical costs. So it was an effective intervention. Another study showed that if you take patients that have a chronic illness, an example would be something like chronic pain or diabetes, and if you send them to either 7 to 8 small group sessions where what they focus on is basically managing their disease more effectively, they found that that program cost $1 per person, but it saved in their medical costs $10 per person. So a tenfold return on investment. That's pretty good. And again, it's just kind of going back to that information decision support and going back to the behavior change. It's just giving these people what they need. It's giving them the education, it's giving them the information, it's helping them understand what's going wrong in their body, it's telling them what kind of lifestyle behavior things that they can do to manage their disease more effectively. And it also is going to focus on, we haven't really talked about this yet, it's going to focus on medical adherence. Sometimes we call that compliance. Compliance makes it sound like you're supposed to do what the authority figures do. So adherence makes it sound like you're more of a human being and you can be encouraged to do something, but you can choose to adhere to the medical regimen, or you might not adhere. So we call that non-adherence or non-compliance. Psychologists get a lot of referrals because of that. But if they understand how the behavior is linked to what you're asking them to do, they're a lot more likely to do it. So again, we've got some effective ways of intervening in the somatization disorder pathway. Let me tell you real quickly about a honors thesis that we did that kind of hits home how important this kind of thing is. This was Amaka Imo. She is in med school right now. And she was my honors thesis student. And we were interested in looking at, in college women, how interpersonal violence, both physical dating violence, as well as how sexual assault, so sexual violence, was affecting these women. And one of the things that surprised us a bit in these women is that we found that 47% of college student women, so like in the audience in this class, unfortunately, had experienced some form of interpersonal violence. And then we also asked them if they had experienced multiple forms of violence, so both physical violence as well as sexual violence inflicted on them. And 46% of them had experienced what we call polyvictimization, meaning multiple forms of violence. And we know in the interpersonal violence literature that one form of violence can be harmful, but having multiple forms of violence. So an example could be things like even child abuse, physical violence plus sexual violence. Polyvictimization tends to create more psychological disorders and more medical illness in individuals who've been victims of that. And then unfortunately, this is some of the stuff that we study in my women's health lab. Unfortunately, having been a victim of violence oftentimes changes a person's life trajectory. And I find that to be very sad. And I have a lot of compassion for that, because you could experience this unfortunate event in your life that you had no control over, and it changes your life trajectory, even your education level, etc. Now, what we found that when we looked at regression analyses, polyvictimization was most related to somatization disorder, which again are the frequent flyers in the healthcare system. So we really should be screening in the healthcare system for psychological disorders, and we really should be screening. It's why I add those items on my Prime MD when I use it. We need to know if the person that we're working with has this history of victimization. Because a lot of these individuals have somatization disorder, a lot of them have depression, a lot of them have PTSD, a lot of them actually have substance abuse disorders, and we want to be able to effectively treat that. Second to the somatization disorder, polyvictimization was most predictive of suicidal ideation. And I think about in the psychological disorder literature, suicidal ideation is the epitome of illness, if individuals are considering ending their life for that. So again, just a link here, since we've been talking about somatization disorder, but I also want you to know how important these psychological and interpersonal violence events are in people's lives and what they predict. Okay. So we've gone through the Friedman et al. Pathways. I love those pathways. Even though that article's out of date, I love teaching about them again, because I think it really helps us to understand what are the things that we can do that are win-win-win, that improve quality of life for the patients that we're serving, save in cost, the consumers, the people who get these interventions really like them. Okay, so now we're going to switch gears, and I want to point you to the Walsh American Psychologist article. He talks about 8 therapeutic lifestyle changes. He calls them therapeutic lifestyle changes. I wish they were called, ideally they should be ordinary lifestyle behaviors that everybody's doing, but everybody's not doing them. But his point is that these lifestyle behaviors are underutilized by healthcare providers. Okay, so even when we know scientifically these 8 TLCs are really effective in improving quality of life and mental health in patients, healthcare providers aren't recommending them. Now, like we said in that domino effect thing earlier, a lot of times healthcare providers aren't recommending them because they don't do those healthy lifestyle behaviors themselves. And so that's why we want our healthcare providers healthy. So they're recommending and counseling their patients more effectively in that. Okay, we are going to be integrating this stuff all semester long. And one of the things that I really like that Walsh has done in his article, and we're going to be hitting home on this a bit all throughout the semester too, is that our physical, behavioral, emotional bodies are wired in certain ways, and we have landed in certain ways based on our ancestry, based on evolution and survival of the fittest, Darwinian evolution, all that kind of stuff. And a lot of what ails us nowadays, both in he focuses mainly on the mental health, but we're going to focus on mind body, so we can be thinking about physical health here too, is that we used to live in an environment when we were dying because of lack of survival of the fitness, and dying and then not reproducing and sending our genetics down the line with our offspring. We lived very differently. We mainly had a hunter-gatherer type of thing. We lived in tight-knit social communities. We moved a lot. We ate a lot of plants-based, or we ate fresh meat. We, in that tight-knit social support, were connected with others and had that support. We didn't have the isolation. We slept on the ground, usually in tents, teepees, whatever you might think of, but we were not insulated from the ground with shoes with rubber soles on them. We spent a lot of time outdoors in natural light. A lot of times there was a great spiritual connection either to nature and the earth, or religious connection, a belief, in God or gods and that type of thing. So the way that we evolved is not the way that we are living. Most of us, is not how we are living our lives nowadays. And so when we start thinking about Why have mental health issues increased over time? And I can tell you that your generation of young adults is experiencing more psychological distress than previous generations. The American Psychological Association tracks that in these surveys every couple of years, and you all are in rough shape overall. But the good thing is your generation culturally is more apt to being willing to go get help, to get counseling, psychotherapy, that type of thing, than previous generations. So that's good. Stigma's reduced, but you all are in rough shape. And if you're in rough shape, shouldn't we be asking why? Yeah, and there's explanations for that. Also, when you look at inflammatory conditions, we're going to talk more about that later. We've seen a rise in those conditions in recent medical history. And that begs the question, why? What's going on? Well, we can point to some of the things that are going on. And so let's get started on that. So definitely read this article. Number one in therapeutic lifestyle change, he says exercise. Okay. I am a huge fan of exercise. I recommend exercise to all of the clients that I see. I preach this in class, in all of my classes, doctoral level, this class, that type of thing. Both aerobic or cardio and resistance weight training, we know are beneficial for the mind and the body. And there's some really interesting biology and chemistry underlying all of that. I'm not going to go into detail about that necessarily this semester, but we will have a lecture on exercise a little bit later. We know that the benefits to mental health are amazing. We are relying way too much in our culture on medications for mental health when we should be advocating this stuff here. It improves depression. It improves depression quicker than medication, and it's win-win-win. Medication has side effects. Most people nowadays are on things like the SSRIs, some of the older stuff, the tricyclics, the MAO inhibitors, that type of thing. We know that exercise decreases cognitive decline and improves memory. And for you students who are learning a tremendous amount in college, there are a couple of things you should be doing to take the information that you are learning and cemented it into long-term memory. And the basics of that is you should study, not just read, but study and rehearse and quiz yourself. That's part of the study buddies in this class. Quiz yourself. Get good sleep after you have learned, eat healthfully, and exercise after you have learned. All of that kind of stuff is going to take that information and more efficiently put it into long-term memory. So not only can you perform well on an exam and take that information and remember it or integrate it or apply it, but remember it forever, which is important, right? Particularly depending on what careers you're going to be doing. And one way I think about this pretty simply is a well-nourished brain and a well-oxygenated brain is going to perform better than a brain that has really poor blood flow. Okay, so pretty simple here. When we exercise, we're getting a lot more blood flow to our muscles, a lot more blood flow to our brain. There's even some interesting data on raising our body temperature when we exercise and sweat, the benefits of that to the brain. All right, so much of the anxiety that people are experiencing nowadays is because they're perceiving threats in their environment that are modern threats, like pressure to perform well on an exam. Our ancestors did not have those kinds of stressors in their lives like we do now. And so much of our anxiety is because we just simply haven't moved and burned it off. Okay, burned off that energy. And so you all test this out yourselves. I mean, if you go and exercise intensely, it's really hard to kind of feel anxious after that. We get this nice kind of calm down after it. We know that exercise is beneficial in addictive disorders because exercise, it can give us that endorphin runner's high, but you don't even have to exercise that intensely to get that kind of thing. But it makes us feel good. And when we feel good, we're not reaching out for substances to artificially feel good. We know this is beneficial all across the lifespan. It can be beneficial for kids, midlife, young adults, elderly. Exercise is good medicine. TLC number 2, food and nutrition. He simplifies ideally how we are eating, and he calls it the rainbow diet. And I love that. I mean, look at this, just beautiful, beautiful plant food here and how colorful it is, the color of the rainbow. Now, he points to the fact that some of us mammals, but especially us human mammals, have evolved to see in color. And that has been beneficial across evolution because as we were gatherers, and then once we started an agrarian lifestyle and growing our own plant food, being able to see brightly pigmented food was an advantage because that brightly pigmented food is the healthiest food out there. And so if we can see it and we can get it and we can consume it, our bodies and mind are getting the nutrition that we absolutely need. And so that rainbow is a way of thinking about getting particularly the plant-based foods and all of the nutritions that we need. We're going to spend more time at the very end of the semester talking about nutrition. But I want us to think about the typical American diet, and let's think about fast food there. It is not brightly colored. It is beige and brown, okay? Particularly when you think about a cheeseburger, French fries, maybe a milkshake added to that. That is the opposite of what we're talking about here. So the rainbow diet, lots of fresh fruits, vegetables, whole grains, legumes, which are the beans. And then he also talks about, excuse me, fish, fish and things like flaxseed, some plant-based fats, fatty acids that are really healthy to us. He's recommending, and this is true, most Americans could deserve to reduce their energy intake, their overall calorie intake, particularly calories that are coming from animal products and animal fats. We know that eating a really healthy diet improves our cognitive functioning. There's some really interesting data on how it improves academic success in kids. It improves academic success in college students. We know that following a rainbow diet is really healthy, even for really serious, severe mental illness like schizophrenia. We know that diet can be very helpful in preventing or treating bipolar disorder, major depression, which are the affective disorders. We know there's research out there to show that a Mediterranean diet, which is mainly plant-based, and then adding things like fish to the diet, this is how people eat over in the Mediterranean, mainly plant-based, reduces onset incidence, is the case, new cases, onset of things like Alzheimer's disease and Parkinson's disease, which are very serious brain diseases. So basically, we are what we eat. So there's really good data to show that eating more plant-based rainbow diet is preventative and really can be effective in actually treating lots of psychological disorders and lots of physical kinds of disorders. So good stuff here. Okay. He also presents some research on not only just healthy eating, but supplementation and some of the things that we probably should be doing, particularly if we've got genetic loadings and we've got vulnerability for certain types of disorders. So he talks about the fish and the omega-3s. Again, we can get some of those from plants like flaxseed, chia seeds, things like that. We can also get it from fish. How powerful supplementation with the omega-3 are for schizophrenia and bipolar major depression. He's been able to show in the science that it's helpful for unipolar, which is depression, bipolar, which would be manic depression, perinatal, which would be postpartum depression, effective. It's got a recommendation for the dosage. Been able to show that this decreases aggression, ADHD types of behavior in children and teens. And this is, man, this should be recommended in emergency departments when they see anybody who's having a psychotic break. Prevent the onset of psychosis in people who are vulnerable for schizophrenia. So anybody who's got a family history for schizophrenia, they should be recommending and leaving people with a recommendation for supplementation when they've had a psychotic break and have visited an ER, been in a psych hospital. This is pretty powerful stuff, you all. for not only the ordinary psychological disorders like depression, anxiety, ADHD, that kind of stuff, but for the really severe stuff too. Some other supplements that he's recommending, vitamin D technically is not a vitamin. It's actually a multi-purpose hormone, but we call it vitamin D. It is neurotropic, meaning healthy nervous system in the body, healthy nervous system in the brain. It's an antioxidant. It's an anti-inflammatory. And we know that when people have low levels of vitamin D, not only is that dangerous for inflammation and physical health, it is dangerous for psychological disorders. Low vitamin D is associated with cognitive impairment, cognitive decline, so a reduction in ability to memorize things and learn things. So it's implicated in senility, dementia, Alzheimer's disease, as well as vascular dementias that cause cognitive decline. Low levels are seen in people with depression. Whenever I work with clients that have, they come to me with medical illness, they come to me with psychological distress, I usually recommend that they get a medical checkup and that they get blood work done, where not only do we look at things like immune function, thyroid is important, particularly for depression, but I want to see their nutrition markers. So I want their medical professional to get us that information for us to take a good look. What does their vitamin D look like? What does their vitamin B12 look like? Are they showing any type of malnourishment info? Are they showing overnourishment? They're consuming too many animal products, and their cholesterol levels and their triglycerides are high, stuff like that. We know that this tends to be low in bipolar, schizophrenia, recommendations for vitamin D supplementation. And then we're also going to talk about exposure to sunlight, which is, helpful in making vitamin D. Basically a diet that's good for the brains, good for the body. We're looking at here, we got all this stuff that's got nice vitamin D. We do not have to consume milk and animal products to get vitamin D. But again, for people in these vulnerable places, ideally are supplementing their vitamin D. TLC nature. I love this one. Okay, I love this quote. Imagine a therapy that has no known side effects, was readily available, and could improve your cognitive function at absolutely zero cost. It's free. Nature. We evolved to spend a lot of our time in nature. We evolved, again, sleeping on the ground. We evolved moving around outside in nature very frequently in the hunter-gatherer society. And that's not how most of us spend our lives. Now, I can appreciate, I enjoy living up here in the high country. Many of you probably have come to AT because you like being out in nature, which is wonderful. If you're not doing it, I'm going to really encourage you to do it. You don't have to go very far around here to be able to find some amazing beauty and nature. Go out to the parkway and take a look at Grandfather Mountain. Go find a trail, whatever it might be. Go to Rocky Knob and mountain bike. Figure out how to find nature. Okay, most of us live in artificial environments. We live in artificial lighting most of the time when we're inside. And we know that being in an artificial environment lowers our attention span. I know a lot of people think they have ADHD when they don't, but they're just spending too much time in an artificial environment, spending too much time on a screen. I know you're on a screen right now, sorry. We know that it creates problematic sleep, poor sleep quality. We know there's a decline in your academic ability when you're not spending enough time in nature. And then when you're spending too much time on screens, which Walsh calls technopathologies. So being immersed on screens, on phones, on tablets, on computers, this media immersion taps your attention. Okay. It can create what we call this digital fog, where you're just like, oh, I can't think clearly. I can't remember things, that type of thing. When we attempt to multitask, that's why say looking on your screen and your phone when you're driving, that's just a formula for a motor vehicle accident. We can't multitask very effectively. We try to, but we can only pay attention to one thing at a time effectively. So he calls that frazzing when we're, attempting to do that. And then there's the addictive nature of social media. So an example would be somebody that really, they post something on social media and they're really looking for likes, that type of thing. There's even some data to show that low self-esteem individuals, when they post on social media and they don't get the likes that they want, they pull that post down. Gamers, I can tell you one of the places where psychologists get snagged up into industry is in the gaming industry, because we know people are more likely to play a game, tell their friends, buy the game, if the game is set up to engage in a certain reinforcement pattern that we call intermittent variable ratio reinforcement. That makes a game addictive. If you play a game and you don't win at something or move to the next level, whatever it is you're after in that game, you're going to quit playing that game and you're going to tell your friends it sucks, and then nobody's going to buy that game. Word of mouth. Okay. So psychologists are employed in how to capture your attention and keep you locked into various games. That doesn't happen accidentally. It's programmed, and psychologists are involved along with computer engineers and whatever in designing that stuff. He also talks about hyper reality, where people who spend too much time, you see this more in elderly people. Let's say they're spending all their time watching CNN or Fox News, and they just like the news cycle, it goes 24/7. When I was growing up, we watched the evening news a half an hour every evening. That was like a family ritual with my family growing up. It was a family ritual when my sons were teenagers. We would watch a half an hour a day. Now you can sit there and watch very, very depressing, upsetting news 24/7. And when people do that, they start thinking the world's coming to an end. As opposed to, again, getting out in nature and sort of feeling like, oh my gosh, look at the blessing, and this beauty of that kind of thing. So this idea that when you're what feels like your reality is screens or 24/7 television and news, it really distorts life. Okay. And again, it's so different than how our ancestors evolved. Okay. So he comes up with this term, and I love this because I think it's accurate. Most people don't go to the doctor and come out with a diagnosis, hey, I got nature deficit disorder, but it's a real thing. And again, going back to this idea, what if ADHD, and what if anxiety disorders, and what if stress, and what if depression, and what if schizophrenia, all that kind of stuff is really these deficits and all this stuff that we're talking about. Okay, we know that I had this beautiful clip that is missing now, but it's really funny. I wish I could show you. It's from Outside Magazine, but I can't find it anywhere. So this link doesn't work anymore. We know that being in nature improves our cognitive functioning. It improves our ability to attend for long periods of time to information. It improves our emotional well-being. It improves a sense of spirituality. If you feel connected to God, if you feel connected to nature, if you feel like you're kind of connected in this world, sometimes being out in big nature, which I absolutely love, makes me feel small and humble. And that's probably good for a lot of us because we get so into ourselves and our ego. And I think it's good to be humbled sometimes. And improves our subjective well-being. He also talks about the gift of silence. It can be just so nice being out in nature and hearing birds chirping, crickets at night, just the sounds of silence. I know my family and I, we went to New York City a couple Christmases ago. It was great being up in the city, seeing plays, doing stuff, being in Times Square. But I remember coming back to Boone and just like, it's so nice not hearing sirens and horns honking and people talking and the bright lights of Times Square, that kind of stuff. So the gift of silence. And we know that being out in nature is just so good for our mental health, all the stuff that we've talked about. Okay, I'm going to call an end to part 4 of this intro lecture. So we're going to end here with nature, and we will pick back up on the next part with relationships. So see you soon. Bye.